All right, so we'll go ahead and get started with today's Sports Ultrasound Case Series presentation. I have the pleasure of introducing Dr. Jeremy Roberts. He currently is a PGY-7 Sports Medicine Fellow at Atlantic Sports Health, Morristown Medical Center in Morristown, New Jersey. He previously completed his residency in PM&R at the New York Presbyterian Hospital, Cornell, and Columbia, and a fellowship in pediatric rehabilitation at Children's Hospital, Colorado, University of Colorado, in Denver. And today he's going to be giving us a presentation on an LCL sprain.
All right, good morning. As Dr. Schaff mentioned, I'm Jeremy Roberts. I'm a sports medicine fellow at Atlantic Sports Health in Morristown Medical Center in New Jersey. And today we have an ultrasound case presentation on an LCL sprain. So our objectives today are to review the protocol for ultrasound imaging of the lateral knee, to discuss any pertinent pathology of the LCL, and then to very briefly review any ultrasound-guided treatment options of LCL pathology. All right, so very briefly, we're going to go over our two cases. The first one is chronic, and that's going to be the crux of the presentation. So we have a 59-year-old female who's a dance class teacher presenting with 1 year of lateral knee pain. About 1 month before presentation, she noted a popping in her knee during spin class. She had felt swollen and stiff, resulting in limitation in activity. Reported worsening power, instability, and buckling. Worse with high resistance, but continued to teach her dance classes. She was treated with Motrin and ice, and she trialed a brace. She is a dance teacher, and she is very active in yoga, dance, and Peloton. And we can go over the radiographs and MRI after we go over the ultrasound presentation. And then very briefly, case two, I didn't personally see this case, but it came up while I was working on this presentation. So I thought it was good to have some images as well. So this is a 43-year-old male with a right knee injury after playing basketball 4 days prior to arrival to the clinic. He had tripped, bent his knee awkwardly. He reported a pop, a lateral pain and numbness and tingling in his toes, which later subsided. He had had occasional locking and was treated with ice and ibuprofen. His pain was worse with squatting and walking. He had noted some swelling and locking, and his exam was notable for varus laxity, some LCL tenderness and forced flexion, and his MRI did have an LCL tear, biceps femoris tear, and some bony contusions. So those are our two patients, and again, patient one is going to be where the majority of images and protocol is coming from. So when we think about the LCL sprains, we have to think about the lateral knee protocol at large. The lateral structures are superficial and can be located with ultrasound. You can consider having the patient side-lying or in supine, and you can also assess the more lateral structures while prone, which we'll get to later on, especially with the LCL and biceps and peroneal nerve. The most superficial ligaments will be the iliotibial tract, which attaches to Gerdy's tubercle, and then just lateral will be the LCL, as we can see on some of the images, and that will attach to the fibular head. And the LCL can be assessed dynamically with flexion, which tightens the LCL and can move with varus stress, and will be imaging the structures as noted on the slide. So our first view through our lateral knee protocol will be the ITB. So this runs along the lateral aspects of the thigh and is going to insert on Gerdy's tubercle of the tibia. This is superficial and can be palpated. There's going to be a small bursa located just under the surface as it runs under the femur, and it's going to be a common site of friction and bursopathy. There's also another bursa that lies under the ITB as it inserts on Gerdy's tubercle. Sometimes you might not see these bursa on ultrasound unless there is a pathology. So this is going to be in a longitudinal plane. It'll be just above the femur in a superficial location. You're going to follow it along longitudinally down a coronal oblique scan. When you get up to Gerdy's tubercle, you could do a 90-degree rotation for the short axial plane. And Just near it will also be the lateral geniculate artery, and just below it is going to be the lateral meniscus. And the ITB, as we could see in some of the images on this slide and a couple of other slides, is going to run over the popliteus hiatus, and that is the ITB. And then on this slide, we could see the ITB in short axis in the top right image. And then in the bottom right image, we could also see the ITB running from Gerdy's tubercle at its insertion to the right towards the femur, and with the lateral meniscus forming just deep to it. In our patient, this is her ITB. She did not have any thickening or tendinosis. Next, we come to the lateral joint line, in which only the peripheral aspect of the lateral meniscus can be evaluated, although MRI can better be used to evaluate this structure. When pathologic, you might see any clefts, fluid, or tears, as well as looking for any sparring for degenerative arthritis. When you're over the ITB in the longitudinal plane, you could scan just posteriorly to look for this lateral joint line, looking for the lateral meniscus as a triangle wedge shape, and looking for the popliteus hiatus, which is going to be just proximal, and that's where the popliteus will insert. Of note, there might be some anisotropy, so you might have to scan and tilt your probe. And then here we could see another view of the lateral joint line with the meniscus where my arrow is pointing, and the popliteus tendon running over it. So in our, this is images from our patient. There is a mild meniscal tear that was noted, and there was some fluid as well noted near the meniscal region, though this wasn't the most significant area of our patient's pathology. Moving along the lateral knee towards the popliteus. This will be a posterior tendon on the lateral aspect of the posterior tibia, with the sciatic and tibial nerve running just above. It'll run a sharp and oblique course, and it'll attach the femur under the LCL. And you'll be able to see it in short axis sitting in the popliteus hiatus with the muscle just posteriorly, and we could see that where my arrow is. This one is very susceptible to anisotropy. And of note, the popliteal artery will sit right above it. It'll be at a very oblique angle, which we should be able to see on the next slide. And as we could see in the top right picture, it runs, the muscle itself runs at a very oblique angle. So this is the popliteus tendon in our patient. There's going to be a calcification that we see on a later slide that'll be just superficial, but in our patient, there wasn't much evidence of a popliteus strain or pathology. And now we get to the LCL, which can be done in either sideline or prone position. So with the patient in a lateral side position, you want to move the probe just posterior in the longitudinal plane. You might see the concavity of the popliteal hiatus with, and then following it obliquely. The LCL will be attaching to the fibular head. So in sideline, you're going to look for the popliteus hiatus. You're going to look for the meniscus, and the LCL will run just above the popliteus, as we could see in our image over here. And you're going to line the probe looking for the fibular head and follow along the joint. You can also have the patient in a prone position in almost a figure 4 position, which we'll take a look at shortly. And you're going to aim again towards the popliteus and fibular head. The LCL tends to have a lot of anisotropy, so it's very difficult to follow still LCL throughout. And of note, it'll run just above the popliteus, the vessels, and the joint. So on the left, we could see the LCL being imaged in a side-lying view. And on the right, we could see the LCL being imaged relatively prone and side-lying in that figure 4 position. So of note, again, the ligament is very difficult to isolate in one scan. So you're going to have to look for a proximal LCL near the femur, a middle, and then a distal LCL attaching to the fibular head. And in our 4 images, we have different views of the LCL running over the geniculate artery as well. And this is another view of our LCL and then inserting. And then in our patient, we have a couple of views of our LCL, which did have a significant calcification near the proximal attachment. And this calcification, especially which we could see in the bottom right view, had about 3 components to it with a noted sprain as well. There was significant Doppler positivity as well. So these are all the images from our patient. And as we now go through some of our videos, this is the LCL in long axis, and we could see nice calcification appearing. This is the LCL in short axis with calcifications right in the middle of the LCL. Here we have the LCL entering over the biceps. Here we have and now we did a barbotage procedure. So this was our initial injection into the calcification of the LCL. Here was our procedure doing the barbotage of our calcification into the LCL. Another view of our barbotage with some of the fish mouthing that we noticed. And then at the end of the procedure. And then this is how we had set up the procedure, lining up along the LCL from the femoral condyle onto the fibular head. We had the patient in that figure part, the sideline and part of that figure 4 position in order to line up the probe for both the anesthetic. This is the steroid injection that we had done at the end. And then this was the nice calcification that we had seen after doing the barbotage procedure. It was a little bloody at first, but we could see how cloudy and some of the particle residues that came from this barbotage. In terms of patient 2, very briefly, so this was the acute case. And especially if we look on the images on the bottom right, we could see a huge LCL tear and disruption, along with, if we look at our top left, a lot of disruption of the joint line as well. And then our bottom right image, we could see the LCL tear again, along with the bottom left image, we could see the LCL tear. So again, this was our patient 2, the acute tear of the patient. From the LCL, then we move along to the biceps femoris. And when we think about the biceps, we have the long head that originates on the conjoint tendon in the ischium, and short head originating on the femur, both attaching to the fibular head. So for that, we're going to use a similar position as the LCL, attaching at the fibular head, pointing towards the ischium. And then we're going to look for any, we should see the image in the bottom right. It'll have, and I'll show in a second, the Z. This will complete our Z maneuver. So as we anchor onto the fibular head, aiming towards the ischium, we then should see the biceps appearing in long axis. Of note, the biceps is the most commonly injured hamstring, and we will see a couple of the heads of the biceps attaching over the LCL as well. So this is the positioning that one would take when then looking for the biceps. In the top, the patient's a little more prone, and the bottom, the patient's a little more side-lying. Of note again, this is the most commonly injured hamstring, and we could see a nice picture in general on the bottom left. And then in our patient, she did have some biceps tendinosis, as we could especially see in the near the bottom image, just posterior to the LCL, which makes sense in the context of the large calcification that she had had. And then from the biceps, I like to go into short axis to then look for the peroneal nerve, which you can see in that bottom left image. And it'll be a grape-like structure. You could follow it obliquely towards the popliteal fossa and then over the fibular head, where it could be seen either longitudinally or in short axis as well. And then this is the total. Let me put that on mute. So this was the total scan, and we'll get to a better view of the peroneal nerve. So I like to start at the, as we can see on the ultrasound in the back, and we'll have a bigger image on a future slide. I like to start at the patellar tendon as the home base, just so I know where I am. You could see at the bottom that I'm palpating Gertie's tubercle and looking for the femoral condyle. And if you could see the monitor in the back, that is me trying to get to the IT band and then sweeping and scanning along the IT band, which is then going over the joint line and popliteus hiatus. Next couple of seconds, I'm going to rotate into a short axis view while on Gertie's tubercle. So that's the short axis, and you can see on the screen of the IT band running short axis. And then I'm going to scan a little further again at around the 120 mark. So coming up shortly, I'm then going to be palpating for the fibular head and keeping my probe anchored on that femoral condyle. So that's part 2 of that Z maneuver, where I went from Gertie's tubercle to femoral condyle to fibular head, and I'm lining it up on the ultrasound, and then we'll get a better view of the LCL in a more zoomed in picture. around the later mark. We're then aiming from that fibular head to the sorry, at the 220 mark. We're then aiming from that fibular head towards the ischium to get the biceps tendon into view. So I'm going to be pivoting my probe from there. And right there, that's where I do my pivot to head towards the ischium so that we have our biceps. And that was that Z maneuver. Again, Gertie supraglottal femoral distal femur to fibular head to ischium. And then at around the 320 mark, then I like on the fibular head, if you could see that screen in the back, and we'll have a clearer video. That's when we're looking for the peroneal nerve, which is then sweeping over that fibular head. And then this is a closer view of the screen, and we could see, again, because it was a little harder to see on the distal view, but our peroneal nerve that will then be coming over the fibular head, and that was in that short axis portion. Very briefly, because then we're getting into posterior knee, not lateral knee anymore. But you can continue your scan looking for the lateral posterior horn of the meniscus using a convex probe. You could do dynamic views internally, externally rotating the leg. You can assess it for any of the articular cartilage of the femur and looking for any cartilage anterior as well, but this would be a view of the posterior horn of the meniscus. This was our patient's posterior view. And then very, very briefly, anterolateral ligament between Gertie's tubercle and the fibular head, aiming towards the LCL. And then this will attach the lateral meniscus and proximal femur. We didn't have a good view on our patient, so this is an image from Jacobson of that anterolateral ligament. So overall, the full report case ultrasound report. So in the suprapatellar recess, which we didn't have image of on this one, she did have some joint fluid and effusion. The ligament did have significant calcifications near the proximal attachment. Calcification seems to have three components in it. There was a noted sprain of the LCL with significant Doppler positivity as well and mild bursal fluid. No thickening or tendinosis of the ITB, no burstopathy at Gertie's tubercle. There wasn't any catching on dynamic exam. Popliteus tendon didn't have any hypoechoic fluid, but calcification was just superficial. Biceps femoris had some tendinosis noted. Tib-fib joint was grossly normal. There was some mild bursal fluid over the lateral femoral condyle. The body and anterior horn of the lateral meniscus showed mild deformity. And there was a infrapatellar mild bursitis as well. So we did a barbotage procedure, as we saw the images of. And then overall, patient one had a very good outcome. She was seen about 4 to 6 weeks ago at this point, and she did have significant improvement with the injection. She felt about 90% better. She's able to dance and do her Peloton again, teach her class. She may have occasional soreness after a busier day, no mechanical catching or locking, less tenderness to direct palpation, and to get that extra 5%, she can consider shockwave treatments as well, but she was very pleased with the outcome. And then patient 2, he at this point was seen a couple of weeks after that ultrasound scan, had been using hinged knee brace, was doing some light range of motion, and he was full weight bearing. He had overall felt better. So that was the two cases. I know it's 8:55, so I could pause there and answer any questions, go back to any slides, share what the MRI findings were, whatever the group would like.
All right. Well, thank you so much, Jeremy, for going over that case. I know with the lateral knee and the LCL, it's a challenge just because one, it's complex anatomy in that region with a lot of different structures. But on top of it, even just with the transducer, as you demonstrated with your videos, there's a lot of manipulation that you have to do with the transducer and a lot of different planes that you have to go into to be able to visualize these structures correctly. So thank you for going over that. As far as just a few comments that I'd make from a protocol standpoint, you had mentioned it in your report, but I know you said you just hadn't demonstrated images of it. But I do think it's important to always take a look at the suprapatellar recess to begin with, just to see if there is any joint effusion. Obviously, in those cases, you'd be much more concerned about intra-articular pathology. Obviously, the ultrasound scan can still be helpful for those extra-articular structures, but may point you a little bit down the road of eventually obtaining an MRI. The other would be the fibula joint as well too, just to see if there's any effusion or pathology at that area. Once again, mentioned in the report, but always I think important to kind of take a look at the underlying joints in those scenarios. You had mentioned as far as the positioning with the LCL, it's definitely can be, very difficult because you don't want to be into full extension or full flexion. Sometimes that can make it a challenge to visualize the LCL, especially with transducer orientation. One thing that I found helpful is sometimes just having a pillow under the knee as well too. That will kind of put some tautness on the LCL, just be able to visualize it a little bit better rather than them going into knee valgus, which sometimes can make it a little bit wavy. No, we don't always think about taking a look at ligaments in the short axis, but for the LCL, I found that very, very helpful to be able to kind of follow up from proximal to distal, especially when you get close to the insertion with the biceps femoris, just because those can kind of go over on top of each other. And so this is one ligament I definitely would recommend get used to scanning in that short axis, just because I think it is helpful to differentiate pathology, especially with the biceps femoris at that area. And then lastly, just with any of these ligaments you had mentioned, but I don't know if we saw any videos, just the dynamic imaging is obviously, demonstrating varus stress on this area, just because sometimes that can be helpful to differentiate a lower grade versus like a higher grade sprain, for these ligament tears. So that's something that you can do for the LCL. Obviously, it can be a little bit of a challenge if you're by yourself, but if you have anyone else that can kind of help to stabilize to apply that stress on that area. So those are kind of just a few of the comments. Otherwise, I'll open it up for any other questions.
Yeah, this is Doug Hoffman. Very nice presentation. Very thorough, really nice images. I love that barbitage. Um, it's funny, Stephen. I'm going down my list and I'm just checking off exactly what you said. I always start with the joint suprapatellar recess and just underlining what you say. If I see an effusion, I have a pretty low threshold of going with an MR. And again, short axis of the LCL and the proximal tib fib joint. The other two things I have on the lateral aspect are comments. One is that most fluid that we see under the distal IT band is actually the lateral recess of the knee. On the medial aspect of the knee, that recess is very tight and it's very unusual to see fluid, and if you do, it's pathologic. But on the lateral aspect of the knee, the recess is less taut, and so there's actually a space there. So it's very common to see fluid there, and not to mistake that fluid with a bursa from IT band. I mean, sometimes it can be very hard to distinguish between a bursa underneath the IT band where the lateral femoral epicondyle is and the lateral recess. And then the other is that one area I found really helpful in this lateral scan is looking at the detail of the lateral joint compartment. One of the challenging areas I find in adults is early lateral joint compartment osteoarthrosis, and oftentimes DAMR and certainly radiographs can underestimate. And so oftentimes when I see uh, unusual lateral knee pain, or and this is often a pattern I see, or pain that radiates to the lateral lower leg, and I see marginal osteophytes and some degenerative changes of the lateral meniscus, then I put early lateral joint compartment osteoarthrosis in the differential diagnosis. And sometimes a diagnostic intra-articular injection helps sort that out nicely. So that's the other area, the lateral joint, the lateral aspect in the I find really helpful.
Yeah, thank you for all that feedback. And in regards, we had done a scan of the suprapatellar recess, but good to know for the future to add those images. We did have an MRI, and this patient was being specifically referred for the LCL calcification. So hence it was able to be a little more focused. But I agree with your wisdom that having that extra joint effusion knowledge would be helpful. And yeah, when I had finished the presentation, Dr. Monaco and I were going over the thing that we really could have added, as you mentioned, was looking for that varus stress to assess for any ligamentous laxity, and maybe having had a stress view on here would have just that, to have that extra image would have been nice.
And then, Jeremy, quickly, were you able to see that calcification on the radiograph or the X-ray?
So yes, on the X-ray finding, I don't have it on the slides, but they did. That was the first thing that was noted.
Okay.
Laterally adjacent to the posterior lateral femoral condyle, there were 2 or 3 calcifications, one of which is more dense than the others and appears elongated. Findings are probably secondary to LCL calcification, and then the MRI did have intermediate grade tearing of the LCL with adjacent calcification. With a small tear in the lateral meniscus.
Okay. Yeah, I've seen them more frequently for the MCL, and less occasionally for the LCL. So interesting case.
Yeah, and it was interesting that they came in like a week apart, basically, the
Yeah,
more chronic one and the acute one.
they always come in waves. All right. Well, I think that might be the conclusion. I don't see any other questions or anything in the chat. So if not, thanks again for the presentation. Really appreciate it.
Thank you very much. I had my
Yeah, nice
references on
job,
the last
Jeremy.
slide. Thank you. Thank you. Thank you for the feedback. That'll be helpful as I progress forward, as I have the references on the prior slide. And thank you for the opportunity. This was very educational, very informative, and it'll serve me well in the future.